Living is precious. Living is something that is alive, something that can grow, reproduce, respire, move, and carry out various cellular activities. Having a bad day is also living. But inability to breathe, digest, run, or do the normal life activities, this is what we have to consider non-living. And our role as researchers to concentrate on having the most suitable solutions for the affected patients. And as a start point, my topic is about cystic fibrosis. My name is Merna Ahmed, and this presentation is under supervision of Dr. Hala Isa, and the course director is Dr. Hussein Sabit. And this is the outlines I'm going to cover. Cystic fibrosis is most common lethal genetic disease in Caucasian populations, caused by mutation in the CF transmembrane conductase regulator (CFTR) gene, which is located on the long arm of chromosome 7. To date, more than 2,000 individual mutations have been identified and reported in cystic fibrosis mutation database. The F508 mutant allele, which encodes a single amino acid deletion, which is phenylalanine in the position 508 in the CFTR protein, which composed of 1,480 amino acids, is by far the most prevalent allele, accounting for 70% of mutations worldwide. Mode of inheritance of this disease is autosomal recessive fashion, which means this disease is inherited when the child inherits defective copy of the gene from both parents. CFTR primarily functions as a chloride channel that transports ions across the apical membrane of epithelial cells throughout the body, but has other functions including bicarbonate secretion and inhibition of sodium transport, which are important for the pathophysiology of CFTR deficiency and dysfunction. When mutations occur in one or both copies of the gene, ion transport is defective and result in buildup of thick mucus throughout the body, leading to respiratory insufficiency along with many other systemic obstructions and abnormalities. The absence of functional CFTR protein leads to the inability of chloride to move outward, and the chloride becomes reserved within the cell, along with high concentrations of sodium, so CF patient suite contains elevated sodium and chloride concentrations. Abnormal ion transport across other affected organs including airways, pancreatic ducts, and biliary ducts, a combination of decreased mucolarity, clearance, and altered ion transport allow for bacterial colonization of the respiratory tract. As a molecular diagnosis of the disease, the amplification refractory mutation system, ARMS, is one of the most frequently used methods for detecting CFTR mutations. And as a medical diagnosis, initial diagnosis of CF in children is done via the newborn screening test, which has been required in all 50 states since 2008. If the test is positive for CF, a conventional suite test is performed to provide a definitive diagnosis of CF. If CF is confirmed, pulmonary radiographs are used to monitor disease progression. Radiographs also are commonly used as a diagnostic tool for patients with symptoms reflective of CF that has not been previously diagnosed. Radiographs also extremely useful for diagnosing chronic infection and preventing and managing pulmonary exacerbation. Radiographs also use less radiation than repetitive chest CT scans, a benefit when managing children with CF. Management of cystic fibrosis. Multiple treatments can be used for CF depending on disease severity and progression. Conservative treatments including breathing treatments, annual influenza vaccinations, and symptomatic respiratory treatment are used as a baseline treatment for all patients. Airway clearance therapy to clear the buildup of the mucus is recommended for all patients to maintain adequate lung function. These treatments include flutter valve therapy, mechanical ventilation, manual chest percussion, and high-frequency VAST-assisted chest compression, which is shown in these pictures. And as a conclusion, the increased knowledge of how CFTR dysfunction causes lung disease has resulted in new existing targets for treatment. CF care has largely focused on the downstream effects of CFTR dysfunction, like septum retention, infection, and inflammation. And there have been many advances on those problems. But this is the therapies that aim to treat the underlying abnormality in CF, either directly or through mechanisms that are closely related to the basic defect. The patient survival rate is increasing, and supportive treatment is becoming more widely available. Primary care providers must be able to recognize symptoms of CF and provide accurate and effective treatment. Also, primary care providers must understand how to monitor and educate patients in order to slow disease progression and help patients achieve the best quality of life. And in the end, thank you for listening to me.